Vertigo in the Diving Environment by Dr. Cecilia Roberts, performed by Dr. Frans Cronje. In this edition, we're going to learn about different types of vertigo the divers experience and how they can be avoided. The word vertigo is derived from the Latin word vertere, which means to turn. It's a special kind of rotational dizziness in which an individual experiences the sensation that they or their surroundings are moving, whirling or spinning in the absence of actual movement. They may also suffer from light-headedness, confusion and a loss of balance. Giddiness is a term frequently used to describe what one is feeling. Vertigo may be accompanied by nausea, vomiting and even ringing in the ears or tinnitus and hearing loss. Uncontrolled eye jerking can be observed on close examination. Vertigo may sometimes be a normal phenomenon, such as following actual spinning, like after getting off a merry-go-round. Once the body has come to a standstill, the fluid in the semicircular canals of the inner ear continue to move, and this can cause a mismatch between what your eyes are seeing and the internal sensory input. With a lack of stable visual reference point, one has an additional effect. Vertigo, as a disorder, is usually associated with a variety of diseases or disturbances of the balance organs of the inner ear or vestibular nerve, which is supposed to carry signals from the balance organs. This may be the case with Meniere's disease, benign positional paroxysmal vertigo or BPPV, ear infections, and vestibular neuritis or inflammation of the nerve. It may also be the result of disturbance of the brain and its centers, which process the signals, as may be the case with stroke, head injuries, or so-called degenerative diseases like multiple sclerosis. Other causes of vertigo may include concussions, migraine, and substances like alcohol, drugs, or medication. In the diving environment, there are many stimuli that may produce vertigo. There are also a number of diving-related illnesses and injuries that may produce symptoms of vertigo. If vertigo is temporary, it is usually benign and therefore just related to the stimulus. If it lasts, it is usually more serious and related to some damage or disease. The stimulus-related causes are broadly classified into two types: so-called unequal stimulation of the inner ear or an unequal response by the balance centers. Some of the different causes of vertigo, which may be experienced in the diving environment, will be discussed in greater detail. The first one is caloric vertigo. This is a passing form of vertigo that is experienced mostly because of unequal vestibular stimulation by cold water. On immersion, cold water usually enters both ears simultaneously, but it may sometimes enter only one ear, such as either when there's an earplug, tight-fitting hoodie, or in the case where the eardrum is perforated and causes the water to directly stimulate the inner ear. This can bring about vertigo. A lump of earwax, swimmer's ear, and bony outgrowths may also cause this interruption, as may foreign bodies and even air bubbles. Perforation of the eardrum is a brief but dramatic cause of significant vertigo. With descent and difficulty equalizing, there may be a pop or a sharp stabbing pain in the ear, with cold water rushing in, followed by vertigo. This usually lasts a minute or so as the water warms to body temperature and then subsides. In the diving environment, the three major predisposing factors that may cause rupture of the tympanic membrane and lead to vertigo are middle ear barotrauma of descent, forceful equalizing techniques, and shock waves, such as when falling on the ear as you enter the water or an explosive discharge in the water. The next condition is alternobaric vertigo or ABV. This is quite a common cause of vertigo and accounts for about 60% of vertigo in divers. Ironically, it's evidenced more in experienced scuba divers. It usually occurs during ascent as a form of reverse block, but it can also be experienced on the way down, the squeeze version. With a change in depth also comes a change of pressure and volume of middle ear spaces. If one ear equalizes at a different rate, and the change of the position of the ossicles, that is the little bones of the middle ear, is different because of different deviations of the tympanic membrane, it may cause a confusing signal in the inner ear and cause the brain to interpret this as vertigo. A sudden or rapid ascent, such as bolting to the surface due to panic, may even worsen this effect and the asymmetric pressure difference. The best way to avoid alternobaric vertigo is to do a gentle and slow ascent. And if it were to happen, one should hold off further ascent until things steady. Ideally, either holding on to a fixed point such as a shot line, or at least focusing on a fixed point such as another diver or part of the underwater landscape. Equalizing attempts, that is, active blowing, should not be attempted during ascent. Apart from representing breath holding, it may actually make symptoms worse. Usually symptoms resolve on their own, and trying to yawn or swallow or wiggle the jaw may sometimes improve the difference of pressure between the ears. Although not dangerous in and of itself, alternobaric vertigo can be hazardous if it causes panic or uncontrolled ascent or breath holding. Nausea and vomiting may also cause breathing stomach contents, causing disorientation or having trouble with navigation. An accidental descent or ascent may cause further injuries. Again, to avoid alternobaric vertigo, it is wise not to dive when feeling ill, with a head cold or congestion, as this may increase the chances of a reverse block. And never force air into the ears. If you have previously encountered ABV, avoid diving when the insides of the ears feel sticky, and remember to ascend and descend slowly and to equalize early and often. It is important to consult a diving medical practitioner before diving if you have a history of eustachian tube dysfunction, serious middle ear infections, or a history of swimmer's ear. One of the causes of vertigo that may be harder to treat is inner ear decompression sickness or bends. It's fortunately quite rare. It's more common in technical and commercial diving, particularly when dives are deep and helium is used as a breathing gas. Helium may be associated with so-called counter-diffusion of gases, and the uneven exchange of inert gases in the structures of the inner ear are thought to cause these bubbles. It may also be possible in air scuba diving following a rapid ascent or after a long bottom time. Vertigo is usually delayed and only starts after decompression or when the person is back in the boat. It lasts longer than alternobaric vertigo, which is almost always resolved within 10 minutes or less. Nerve-related hearing loss is also present in some cases. The initial management is the same as for all cases of decompression sickness and starts with 100% oxygen, unless of course the diver is unable to protect their airway and vomiting, in which case this needs to be supported first. Plenty of non-alcoholic isotonic fluids should also be administered if the person is able to swallow, and they should be transferred to the nearest medical facility for assessment and, ideally, rapid recompression. It is important to distinguish between inner ear barotrauma, which is the result of pressure change, and inner ear decompression sickness, which is the result of bubble formation. The management of these conditions differs completely. It can sometimes be tricky or difficult, although usually a thorough history and examination will make it possible to draw the distinction. Barotrauma. As mentioned previously, barotrauma of the external, middle or inner ear can all cause vertigo. Often this is the result of forceful attempts at ear equalization. It's more likely when a diver descends head first, and less severe if the diver descends fins first. The inability to equalize the middle ear space may produce unequal pressure gradients and vestibular confusion that is similar to alternobaric vertigo. But forceful attempts of the middle ear can cause the inner ear membranes to rupture and cause fluid leakage and vertigo. ringing in the ears, or hearing loss after a no decompression dive, particularly if there have been difficulties with equalizing, should prompt the possibility that inner ear barotrauma may have happened. Referral for medical assessment and rarely repair by an ENT surgeon may be required. Gas toxicity. Because of the interference with brain function as a whole, various gas toxicities may also cause sensory disturbances, which include vertigo. Nitrogen narcosis, which is usually experienced when breathing air at depths greater than 30 meters, can cause dizziness that may mimic or contribute to vertigo, especially if this is combined with dysbaric, alternobaric, or caloric stimuli. On the other hand, high carbon dioxide levels can also cause disorientation and be confused with vertigo. A sudden reduction in high CO2 exposure may also cause vertigo as a result of the so-called CO2 off effect. Vertigo can be a well-known warning sign of central nervous system oxygen toxicity, and this is often seen when divers use oxygen, gas mixers, or rebreathing equipment. It is always recommended to maintain safe oxygen exposures, meaning oxygen time pressure limits. Lastly, high-pressure nervous or neurological syndrome, HPNS, may occur with deeper diving to 150 meters on, and is therefore associated either with commercial diving or deep technical diving. The rapid compression can also cause vertigo, nystagmus, nausea and tremors. Apart from toxicities, low levels of oxygen and carbon dioxide may also cause vertigo, as, in rare instances, may poisoning with carbon monoxide. Sensory deprivation. Lack of sensory input, particularly spatial orientation, is likely to produce vertigo, or at least a sense of disorientation. An example may be a fear of heights, which may be experienced when scuba divers look into deep waters and may actually develop a fear of heights. It can be overcome by focusing on an object in the level plane of vision and by swimming along ledges, the seabed, or the surface. Motion sickness. Motion sickness is thought to be the result of an asynchronization between visual, inner ear, and body position cues, as may happen when being on a boat or in an aircraft. Divers often suffer from nausea, vomiting, and vertigo, even fainting on the dive boat or while decompressing. And lastly, the so-called Tullio phenomenon. This is a fascinating but very rare condition in which exposure to large noises, such as may occur in compression chambers without muffling systems over air inlets, in helmet divers, caisson workers, air crews, or other individuals exposed to loud noises. The most pronounced version is associated with a leak or hernia of the upper semicircular canal. The bulge causes essentially a third window effect, meaning that in addition to the round and oval windows of the inner ear, there is an additional site of motion, and the imbalance that results in the ear with this hernia causes the brain to interpret the disparate signals as vertigo. In conclusion, whatever the cause, vertigo in the diving environment is potentially hazardous. It should be managed calmly and quickly. A controlled ascent is required with protection of the airway if vomiting does occur. Unless it lasts less than 10 minutes and has no other associated symptoms in the ear or otherwise, further diving should be suspended and a diving medical practitioner should be consulted. Treatment is mostly symptomatic and includes bed rest, sometimes medication like antihistamines, topical decongestants, cortisone sprays, and, in the case of infection, antibiotics or antivirals. Recompression is the treatment of choice for decompression sickness, but not for inner ear barotrauma. If this is suspected, referral to an ENT surgeon or specialist is required.